Considering our next speaker, I want to again recognize America's public health officials, especially the officials that are neighbors at the CDC. They, along with their colleagues at local, state, and federal health agencies, have always worked tirelessly to protect the health and safety of the American people, and they've continued to do so through the pandemic, even in the face of anti-science rhetoric, as well as personal attacks and threats. So I just want to say again to them, thank you. We value your hard work and your partnership as we work together to get through this crisis. And I want you to know that our industry will continue to prioritize standing up for your work and for science. With this, I'm about to turn this over to Dr. Bill Fagey. So for those who don't know Dr. Fagey, he is Emeritus Presidential Distinguished Professor of International Health at Emory University and a Gates Fellow, an epidemiologist who has worked in the successful campaign to eradicate smallpox back in the 1970s, and as a reminder, that is the only human disease ever eradicated from the planet. He has held many roles spanning his career, including director of the CDC, co-founder of the Task Force for Child Survival, a working group for WHO, UNICEF, the World Bank, UNDP, and the Rockefeller Foundation. Leadership roles at the Carter Center, and served as a senior medical advisor for the Bill and Melinda Gates Foundation. Most recently, he co-chaired, along with Dr. Gale, the National Academy's committee, which developed a framework on the equitable allocation of the COVID-19 vaccine. He is a strong proponent of disease eradication and control, and has taken an active role in the eradication of guinea worm, polio, and measles, and the elimination of river blindness. Dr. Fagey is a recipient of many awards, holds honorary degrees from numerous institutions, and in 2012, he received the Presidential Medal of Freedom for his life accomplishments from former President Barack Obama. It is my privilege to turn this over to Dr. Fail, and thank you again to Dr. Fagey, and thank you again to Dr. Gale in Berkeley for joining us today.
Thank you, Maria. It's a pleasure to be with you, and you are going to be so fortunate to hear two of the most important global health public servants that we have today. I'm so pleased that they could be here. You're going to be in awe of what they've done in the past, what they're doing now. I was looking forward to introducing them, but found out the other day that they agreed to come only if I didn't introduce them. And so, Dr. Helene Gale, you can introduce yourself to the audience.
Well, thanks so much, Bill, and it is really a pleasure to be with you, and to Seth, who we started out our public health careers together in the Epidemic Intelligence Service. So, you know, I'm a pediatrician by background, then migrated to public health, spent 20 years with the Centers for Disease Control, then went to the Bill and Melinda Gates Foundation to help them as they were starting up their global health program, then went on to lead the global humanitarian organization CARE, and then now I head the community foundation, the Chicago Community Trust, the community foundation for the Chicagoland region, where we're focused on the issue of eliminating race and economic inequity. So had a long career spanning global, national, and local public health and economic development issues.
Thanks, Helene. Dr. Seth Berkley.
So thanks, Bill. And I, of course, was with Helene at the CDC also, and then went to Massachusetts to work as a preventive medicine resident in the state health department. But then you, Bill, convinced me to move to Uganda at a time right after President Museveni came in, working for the Task Force for Child Survival. And that was an amazing opportunity for me to work on in Africa, have a real experience of dealing with disease on the ground and rebuilding systems after many years of war. I then went and joined the Rockefeller Foundation and spent many years there. Afterwards, I started the International AIDS Vaccine Initiative. And from there, I went to be CEO of Gavi, the Vaccine Alliance. Here, I not only am CEO, but I also am the co-lead for the COVAX facility, where we're trying to drive the development of COVID-19 vaccines for the world, which I'm sure we'll come back to.
I will say that both of us have the distinction of having multiple parts of our life be determined by a Bill Fagey ask. So,
As it should be.
as it should.
Okay, we are going to look today at some of the lessons that we developed 50 years ago in smallpox eradication. And we're going to ask our two panelists to reflect on their experiences with these lessons. The first lesson, Stephen Hawking said that the history of science is the gradual realization that things do not happen by chance. They are not arbitrary. This is a cause and effect world. With smallpox, we realized from history that people were very fatalistic about it in many places because they did not know what caused it. And then in both India and in Africa, deities developed around smallpox trying to explain it. But in 1796, the doctor from the UK first used cowpox vaccine, and he showed, even though he didn't understand anything about viruses or vaccines, he showed that you could prevent smallpox, and this went from being a mystery to understanding. So, Helene, you've worked around the world in different places, and you've seen this realization that people now come to believe something. Could you tell us about some experiences you had?
You know, when you were talking about that, it reminded me of the early days of HIV and AIDS. And for those who remember back then, you know, HIV was, or at that time, AIDS was this kind of mysterious disease. And, you know, we took an approach that really focused on who was getting infected, as opposed to really thinking about the cause and effect as you started out with. And so, you know, we saw that it was affecting gay men. We saw that it was infecting injection drug users. It seemed to have a concentration in people from Haiti. And so we started talking about the 4 H's: heroin, hemophilia, because it was also impacting people with hemophilia. So heroin users, hemophilia, Haitians, and homosexuals. And even the way in which we talked about these things, you know, we talked about them in a way that I think biased people's feelings about this disease, as well as the populations that it seemed to first be impacting. And I think it kind of blinded us and kept us from actually looking at the cause and effect as directly as we could have. Obviously, we went on to realize that this was a bloodborne and this was an infection, it was a virus, that it could be carried in blood and other bodily fluids. And that really then did help to understand why it had impacted certain populations before others. And we started to look at some of the geographic traces and patterns for why it might have affected, for instance, Haitians earlier than other populations. But I think it was by labeling populations as opposed to thinking about the cause that we were further behind in making some of the connections. And in the meantime, I think we also did a lot of harm by stigmatizing populations as opposed to thinking about that cause and effect.
Okay, but you did, before a virus was ever isolated, you were able to come to some conclusions on how this virus spread. And I'm always astounded that what you put out as guidelines of how to prevent the virus turns out to be true 2 years before a virus was isolated.
Exactly, by looking at the patterns of disease.
Second lesson that we learned in smallpox is know the truth. You simply can't do anything about a disease problem if you don't know the truth. And Einstein said that if you know the truth, you have an absolute obligation to use the truth and to share the truth. In smallpox, we had to find every person with smallpox and then do contact tracing to see who else was at risk. It was an enormous job. Now, Seth, you've had some experience with truth-telling in Africa that changed everything. Could you share that story?
So thank you, Bill, and let me connect it to what Helene was talking about, because this was during an early era. You sent me to Uganda to help them rebuild the immunization program, and I landed there, and I asked the question, what's the sex distribution, the gender distribution of HIV? How many women, how many men? And people said, well, that's a good question. And I just began to collect some basic epidemiology data that led to working on a case definition and eventually doing a national serosurvey. So first national serosurvey. So we did that, and we got a sample for the country, and then became the difficult situation of what to do with that. And at the end, we met with the president, Yoweri Museveni, and we told him that, and I remember being very nervous and having very wide confidence intervals on this, given where we were. And what was interesting about that is people were like, you can't say this to the president. He then went on the next day, and we had in the newspaper published headline, 760,512. This is after I had confidence intervals that were almost 500,000 apart. But what was really interesting is President Moi in Kenya and President Mobutu in Zaire both were denying that they had HIV because they were worried about tourism being affected. And because President Museveni was willing to come out and use that truth, that of course led to lots of assistance, their ability to build a really strong program, and using the surveillance data to be able to track it over time. And eventually others realized that this was really important. So that led to, some real truth telling from a political leader.
Could you finish up on that story to talk about the role of Fidel Castro?
Yeah, so it was interesting because I think one of the reasons that President Museveni understood the importance for truth was he had come to power after fighting. There had been many years of fighting, and he had come to power as a military leader, and he sent some of his best military leaders to Cuba to be tested. And, my understanding is that, President Castro called up President Museveni and said, to give you some friendly advice as a military leader, we tested your military leaders, and many of them were HIV infected, and you really should be thinking about this as a risk for the country. And that story, which is so iconic in a sense, was important because I think it was jarring. And this was still at a moment in time when people didn't know how it was transmitted, as Helene was just describing. There was a sense, oh, it's only Haitians or it's only homosexuals, and this really was a beginning to understanding of all the different means of transmission that were going on.
Yeah, and I would just say on that, I think, this whole idea of, looking at groups and then understanding what are the commonalities, because you might look at the different groups and they may seem very disparate. It may seem like there's nothing that connects them, but it is in understanding what those patterns are that I think we all started learning a lot more about what really does connect these different groups that seem to be somewhat disparate. And I think it also led us to recognize that it isn't about your group identity per se, or what group you're in, but whether or not you're engaging in behaviors that put you at risk. So I think all of those things kind of came together in the kinds of explorations we were doing at that time.
And some of the debates were, was it caused by mosquitoes? And we had a big debate, were you sharing it by sharing beer and drinking out of shared straws? But one aspect of human nature was that sex is universal. And in this particular case, that was the mechanism of transmission, which is obviously critical then to build safe sex practices in that community.
Okay, this wonderful history and how these things connect to have changed everything that happened then about AIDS in Africa. Well, Helene, you have a history of truth telling to powerful people. Tell us about that.
Well, I guess I maybe would say one story about some of the experiences that I had at the Gates Foundation that you led me to. And, in the early days, when we were first starting the HIV program for Gates, it was very clear that they wanted to focus exclusively on prevention. And for good reason. They really felt very strongly that there were a lot of people talking about treatment, but if you really wanted to turn off the spigot, if you will, then you go further upstream and you really look at prevention. And they really felt that if we could be aggressive in not only behavioral prevention, but also thinking about new technologies for prevention, vaccine included, but also microbicides and other things, we would be contributing the greatest good for the HIV pandemic. But what was becoming very clear is that in some cases, treatment was prevention, particularly when it came to mother-to-child transmission, and that using a treatment modality to break the chain of transmission was incredibly important. And I think that mother-to-child transmission and use of a treatment to do prevention was probably the first step that got the Gates Foundation convinced that in fact it wasn't only traditional treatment. And then I think the other was the clear sense that people would be more likely to take prevention seriously if they felt that their treatment needs were being taken care of. You can't divide a person in half and say, I'm only going to think about the treatment part of that person and not the part of that person who actually already has contracted the infection and needs care. And so we developed the program in Botswana. It became one of the very first programs in Africa that demonstrated the ability to provide high quality treatment to people. And we also found that that enhanced our prevention efforts. And we know the story of Botswana. It had one of the highest rates of HIV infection in Africa. But once we introduced treatment, we were also able to make progress on the prevention side, and we have now seen rates of new HIV infections decrease there. And so I think that lesson of how prevention and treatment go hand in hand was important, but it wasn't obvious at first. It wasn't easy to convince them to move into this treatment arena, but I think once we did, we recognized the importance of having that comprehensive approach.
If I can add to that, Bill,
Sure.
because what's interesting is we saw something similar occur in Ebola. And, when we started with the whole idea of Ebola, with no treatment, no vaccines, and the idea of taking your family member away and putting them and having them die alone, which in many cultures is very difficult, that made it very hard to have this type of discussion. And what's so interesting is that once we had a vaccine that showed that it worked, the idea that you could vaccinate family members went a long way, because then you could protect family members. And so all of a sudden, people were willing to say, I want to talk about this. But what was really interesting is then when treatment came out as well, and all of a sudden you could offer people not only the protection of their family members, but if you could get somebody to treatment quickly, they could then be saved from the disease. It really changed the dynamic of the disease. And so I think this is something that is so important that Helena has said in terms of the way we can bring hope to communities, and with that change the behaviors that are associated with it.
Wonderful. So these lessons continued to operate. So cause and effect, know the truth. But a third lesson, you have to have coalitions. This turns out to be absolutely essential. And Gandhi once said we should spend as much time seeking interdependence as we do seeking our personal freedom. And then he added, there really is no choice. So coalitions turn out to be important. Seth is now running one of the biggest and most important coalitions in the world with Gavi. And say something about how you were able to get this group together and what are the complications you find in trying to run a coalition?
Well, first of all, a little history. Vaccines in the 1970s were not rolled out in developing countries. There was less than 5% coverage. And eventually UNICEF worked to get that up. And then Bill, your role as the head of the task force was to bring together all of the leaders to say, how do we work together to try to expand immunization? How do we leave our egos out of this? And how do we work and move forward? And the challenge then was, how do you systematize that? And so Gavi was formed 20 years ago. And what was so interesting about it is it brought together WHO, UNICEF, the World Bank, the Bill and Melinda Gates Foundation, civil society, all the manufacturers. And of course, it was an experiment. The question was, would it work given these different institutions? And I think the proof is in the pudding. Today, we've immunized an additional 822 million additional children. We've prevented more than 14 million deaths, more than 1 billion vaccinations for epidemic diseases. And we've seen vaccine preventable diseases go down by 70%, which contributed to the 50% reduction in under 5 mortality rate. So it is an extraordinary effort. And the overhead rate is under 2.5%, because rather than trying to duplicate what every partner is doing, we're working together and taking advantage of the systems that are out there. So those are all the good parts. Of course, there are challenges in bringing together groups like this. And what's important is to have a really clear shared mission, and the execution is really important. So we put a lot of effort into trying to understand, how we can have measurable deliverables, how we can constantly work to try to improve on those. And of course, at the end of the day, how can we have clear lines of communications to move forward? Because at the end of the day, people say, it's amazing you do this. We don't vaccinate a single person. This is about helping countries to be able to vaccinate. And we're now pivoting to a new era where it turns out, of course, this is the most widely distributed intervention in the world, but there is still 10.4 million, about 9% of children that never receive any vaccinations at all, so-called zero-dose children. And the question is, can we have countries pivot to finding those families? And 2/3 of them live below the poverty line. And so it's pro-poor. It's obviously a very important gender issue. So can we work to try to chip away at that? And the idea is, by 2030, could we make it truly universal and reach everybody? But to do that, you need the resilient health systems to reach out to these families who, if they don't have vaccine, they don't have anything. So this is really a very ambitious goal going forward.
It's an amazing story, and how much it's improved the life of so many people. And then you have this group, they might as well have been born in the 16th century. They have no benefit from the fact that we have science and medicine or even an alphabet. Helene, you're working on a very timely and difficult coalition process now in Chicago. Can you say something about what you're doing and what you hope the result will be?
Yeah, and maybe I will back up first and just give 2 other examples as Seth was talking, and then I'll spend a little bit more time on Chicago. 2 other coalitions that I was involved in helping to develop. One was UNAIDS, and that was back in the very early days when all of the different UN agencies were doing work in AIDS. I was at USAID at the time, and myself and a coalition of other donors were really feeling like we were being asked multiple times by different agencies for work on their global work on HIV/AIDS, and that it wasn't really well integrated, and people weren't really thinking about what their comparative advantage was. And so we stepped back and we said, let's think about having a co-owned organization whose sole focus was HIV/AIDS, and that could bring the different UN agencies together to have a more focused approach to that. So that was started back a couple of decades ago. The other one was the Global Fund to fight AIDS, TB, and malaria. And in a similar sort of way, there were a lot of resources going into HIV, probably not as much going into TB and malaria, but they were also critical areas of public health importance. And so, again, stepping back, at that time I was at the Gates Foundation. Gates, along with several other both public sector as well as private sector donors, said, let's step back, think about how we can pool our resources so that there could be a more integrated fund that could really go to fight these 3 efforts. And I just say that because I think in the, just like a COVAX and a Gavi and some of the other efforts, the global world is really recognizing that to do these things in the kind of scale that they need to be done, unless we think about them in collaborative ways, we really are often at cross purposes. So, those are just two additional examples. In Chicago, where I am now, we developed a focus where we want to be able to, over the next 10 years, demonstrate an impact on closing the racial and ethnic wealth gap. When we stepped back and looked at all the different issues that were going on in Chicago, whether it's violence, whether it's poor health, disparities in life expectancy, poor nutrition, lack of access to high quality education, etc., that underlying all of those was this staggering gap in wealth, and that it was particularly around racial and ethnic lines because of the historic role that segregation had played in Chicago, like it has in so many of our urban areas. And we saw that Black and Latinx families and communities had little opportunity to have economic opportunity in a way that made a difference. And for our region, where 2/3 of our population are Black and Latinx, we couldn't expect that the region was going to economically move forward if we didn't think about the opportunities that were being held back for 2/3 of its population. So, but to do that, and we're the kind of the principal foundation in the Chicago region, we're not large enough to do this on our own. And so what we've done is to develop coalitions of other foundations in the region, along with the business community and along with the public sector, now all aligned, and particularly post-COVID, where the disproportionate impact, both health-wise as well as economically, on Black and Brown communities has been so pronounced. We are now really laser focused on how do we work across the different sectors to be able to align our work in a way that will have an impact over the next 5 to 10 years on closing the racial and ethnic wealth gap, because we believe it is the thing that is keeping our region back from realizing its full potential.
Okay, quite an objective. A fourth lesson is to respect the culture. Culture really does matter. And because I know Seth has a hard stop line here, I'm going to ask you a question, Seth, to make sure you get this in, and then come back to Helene. In this country, coronavirus has shown the sharp disparities that Helene just mentioned. And that as we were looking at the committee on how to allocate vaccine, Helene continued to make the point that the reason that minorities have more of the disease and more fatalities from the disease is not because of race, it's because of racism. And this division in our culture has become so clear. And you must be seeing that globally. Can you say a word about that? And could you also say just a little bit more about what the COVAX facility is doing?
So thanks, Bill. And by the way, I don't have a hard stop, so I'm here with you as long as you want me. But, it's really interesting. The last pandemic we had in 2009, what happened there was it was swine flu, vaccines were made, but they were bought up by a small number of countries. And then there were no vaccines available for the rest of the world. And of course, that is a huge risk for the world. Turned out that pandemic wasn't so bad, but here we are in a very bad pandemic. And the same thing could happen again. So what we tried to do with COVAX was not just to pay attention to the poor countries, which was critical because you want them to have access to tools as well. But the idea was to create a facility that would bring together poor countries with upper middle and high income countries. And we had no idea whether there would be interest in this in a world that is very nationalistic, that is not necessarily being very cooperative. And it's been breathtaking to see that people are interested. We've had 186 economies join us. We expect that to go to 190 or 195. That's covering 90% of the world's population. And we're in the process of trying to go ahead and have manufacturers scale up doses for those populations. And the goal will be to try to deliver these vaccines across the world at the same time, instead of doing a few countries getting high coverage, trying to do many countries covering the highest risk groups, healthcare workers, and then moving to the elderly and moving to those with conditions to say up to 20% of the population as a way to dampen down the pandemic, because you're only safe if everybody's safe in a global pandemic like that. That's what we're trying to do. But how does that connect to culture? Well, what's happened is with all of this bad information and all of the challenges that exist now and the speed that's occurring, there is a huge amount of fear that's occurring. And of course, what we have to worry about is vaccine hesitancy, which we normally have to deal with anyway. Traditionally, that's a really interesting problem because it's seen more in developed country than in developing countries. Why? Because in developed countries, vaccines are so effective, we don't see these diseases anymore. No parent wants their child to die or be disabled from these diseases, but people don't think they exist. Whereas in developing countries, people see them and they want to protect their children. But now we're here with a novel disease, and when somebody tries to find out about it, they go on the internet, they go to the same social media platforms, and those misinformation can spread literally at the speed of light. So what we need is to bring the local cultures back in. We have to make sure there is the trusted leaders, whether it's the religious leaders or the village leaders or the doctors and nurses that people know and trust, the village elders. We need them to get the right information so that there is a sense of this belongs to us. It's not coming from outside. And with that, then you will have a successful effort to roll out these new tools. Without that, we may be in a situation to have good tools, but not be able to get them to the people who need them the most.
Good. You make the point on the role of fear. And Will Durant once said, the only way we will get the world to cooperate is if they fear an alien invasion. Well, we have surrogates for an alien invasion. And smallpox was a small one. Global warming is a big one. AIDS is a big one. And now coronavirus is turning out to be a surrogate for an alien invasion. The other thing you remind me of is Einstein saying nationalism is an infantile disease. He said it's the measles of mankind. So now, Helene, you actually were changing culture with CARE as you were giving women more power. Can you say something about that struggle?
Yeah, so when I got to CARE and we started thinking about what was the way in which we could make the biggest impact on global poverty, we felt firmly that both because numerically women make up 50% plus of the world, are also the ones that are disproportionately impacted by poverty, that if we wanted to go where the problem was and where the numbers were, we had to focus on girls and women and empowering them. But we also recognize that if you empower a girl and she gets married later, has an education, gets a job, etc., she puts that back into the family, and there's this kind of virtuous cycle that gets created by really investing in girls and women who then invest in their families and invest in their families' future. And so we really did believe that it was the way that we could make the biggest difference. But to do that, we also had to recognize that it wasn't just about empowering girls and women, but it was also changing the way that men and boys think about women, such that the whole society changed in the process. And I can think of many, many examples, but just, one example, we did a lot of work around women's economic empowerment. And there was always the idea that, men are going to be jealous if their wife brings home money, or, they're going to be abused, etc., because men are used to being the ones that earn the money in the family. What we found was just the opposite. By women bringing in salary and contributing to the household goods and the household expenses, they became more valued. We would hear men who say, my relationship with my wife has never been better. I see her as an equal. I respect her. We talk about things together. This is a whole different life for me. And that was in some of the most conservative countries where people often said, you can't change male-female relationships. This is just what is. And I think when you look at culture as not being something that is necessarily permanent, but it exists to create positive change in societies. And when something in a culture doesn't work anymore, and you're able to give a substitution for something that does, culture also changes. So I think we saw over and over again the example of how changing how women are seen, what they contribute to their family, and how they see themselves has a virtuous impact, not only on that woman, but also on her husband and her whole family.
And can I just add another little story to that, because it just made me think of this. We recently did a project with Unilever in India, and they got their marketing people to ask the question, how could they help to lift up immunization at the same time they were working on hand washing and trying to teach that to families. And what was really interesting was we had been giving out a little bag of lentils to kind of reward people, but that turned out not to work, and take a marketing agency to have the smarts to figure it out. And they came up with this really interesting idea to try to label people good parents and give a sticker that you're a good parent you could put on your house. And it turned out that was really good. But what was so interesting was the women were participating, and some of the women said, well, we'd really like the men to participate, but there was a cultural problem because the men, finally, they were able to have some focus groups. It turns out the men initially were embarrassed to be in the same groups of the women to talk about their vulnerabilities and their issues. But once they separated those two groups, they both got interested and began to work together, and then came together as families, like Helene just described, in having a relationship for the good of the family. And so I think this cultural issue, in that case, they were able to overcome some of the differences they had, but it took a little bit of a different way to get it started and some conversations to make it happen.
And I would just add, and as I was listening to your earlier story, Seth, one of the things that I've learned, having spent most of my life working globally and now working domestically in a local environment, is that I actually think in global health and global development, we often do a better job at listening to people and thinking about how we use people's cultures in a more effective way. How do we work with communities? And I think it's a huge lesson for us to learn here in our work. And when we were doing the vaccine study and talking about vaccine hesitancy, and particularly as it affected communities of color, one of the big points we made was how important it was that the messengers be messengers that are trusted within those communities, and that the voices of those communities were lifted up to be able to come up with solutions that made a difference to them. So I guess I would just, my last comment is that I have learned so much from working globally that I think has helped me work locally. And I think there's a lot more we could continue to learn as we think about, how lessons globally can impact locally and vice versa.
These are wonderful stories. I mean, global health stories always are. And we've all seen the bumper stickers about my child is a star student at such and such a school. Now, Seth, there's a whole new market for bumper stickers about how good parents are. So, okay, Helene, Seth brought up the problem of vaccine hesitancy. What is that like in Chicago, and what would you suggest?
Yeah, and I'm starting to talk about that a little bit. I think, we know that there is vaccine hesitancy that existed already. There are just some people, for a whole range of reasons, that don't believe the science of immunization and are not willing to have their children vaccinated. And that's a group that is, very specific, and it's hard to approach. But I think with this vaccine particularly, because of the speed that the vaccine is being developed, because it's been politicized, because people aren't sure whether or not science is going to be tampered with or not. There's a lot of reasons why there has been hesitancy on the part of the American people. Polls say that, anywhere from 30 to 50 and maybe even higher % of the population won't take a vaccine even if it's available. So we've got a lot of work to do at the population level broadly. We've got to get information out. We have to be transparent. We've got to make sure that there's an overarching national campaign that puts the facts out there so everybody is getting common information. But particularly in communities of color, where there has been a longstanding historic mistrust of medical establishment, of experimentation because of ways in which populations have been abused in the experimental process, that we need to make sure we're putting particular emphasis on those communities. And again, having people who represent those communities, who are spokespeople, organizations that are trusted, need to really be part of how we get populations who have perhaps the most to gain because of the high burden of disease. We want to make sure that those populations are getting the information that they need, but it's being done by institutions and by individuals who are trusted, so we can build that trust. This vaccine, as many people have said, we are going to travel at the speed of trust. Vaccination will travel at the speed of trust. It's not good enough to just have a vaccine if nobody wants to get vaccinated.
Good. We have just a couple minutes left. I'd like to give each one of you a minute to tell us, what would you say to leaders? What would you say to young people based on your experience? Seth, why don't you start?
Well, it's perfect because I will build on what Helene just said. And for me, the truth is what has happened over time is we have built up knowledge and science. That's what makes us human. You know, when we die, our children and our children's children, through books, through learning, can be able to carry on and learn and build from what the lessons are before, like you're talking about with smallpox. And so the question for me is, how do we go back to having a society that trusts truth and trust data? It is so critical. Once you lose that trust, building it up is going to be very difficult. So I think we need to get back to, everybody can have their own opinions, but they can't have their own facts. And so I think that's what we have to move back to. And with that trust in science, I think we can do a lot of healing, which is going to be critical for us going forward.
Thank you. Helene?
Yeah, I guess I would just add, maybe reiterate and say it slightly differently, but essentially the same thing. I think for leaders, we've got to have leaders who are trustworthy. You don't just become trusted, you earn trust because you lead with integrity, you lead with transparency, and you lead with values. And I think that's incredibly important as we think about our leaders. And I guess, to the young people, I guess I would say also on the point of evidence and knowledge, it is important. We've been through a period where, people have questioned scientific validity, but it will always be important to lead with the facts, to lead with the evidence. And I guess the only other thing I would say is, I think it's always important to take the long view. It is easy when times get difficult to be mired in that moment. But I think if we're always taking the long view, and if we have a clear sense of what it is we want to accomplish and what we believe in the world, I think we can accomplish great things together.
Well, thanks to both of you. And I would say to the audience, you've just heard two people that have left enormous amounts of good social DNA for the future. Thank you.
Thank you.
Well, thank you, Dr. Fagey. Thank you, Dr. Gale, and of course, Dr. Berkeley. These were really amazing remarks and really putting a lot of truth out there, quite frankly. So, and obviously, Dr. Fagey, you too have left a huge impact on this planet and with our other speakers today. So I know we're at time. Everyone attending, we have concurrent sessions starting in a moment, so please do join us for breakouts today. And after that, we have the innovation stage, so take a check at some early innovations coming out of Georgia University system. And finally, this evening, for those not already registered, we have an outstanding speed networking event with Women in Bio. So don't miss that, and don't forget Women in Bio events, happily welcome then too. So do join us this evening for that speed networking event and connect with a lot of people and learn to inspire and learn from each other. So thank you again, and thank you again to our wonderful panel.
Thank you. I think we are who we are because of Bill Fagey.
Correct. Well,
Great.
thank you.
Thank you.
Thank you.
Thank you.